little bit transformed, but this is the attachment of the middle turbinate. Turbinate is gone. Then you have here the insinate, you see moving, and this is, of course, the lacrimal duct. So there are several descriptions for the incision, but what I recommend is that you start your incision a little bit below the axilla, anterior to the duct. Anterior to the duct. Okay, so here you go to bone. Then, anteriorly, you need to identify the piriform opening. So you palpate. So it could be the level of the head of the inferior turbinate. It could be through the head of the turbinate is not a good landmark. The good landmark is palpation. So when you feel this bony ridge, you incise on it. If you are lucky, you have a Colorado blade. You do it with a Colorado. Otherwise, with not too much power, because you don't want to kill too much inferior turbinate because you will put it back in place, okay? So I cut level with a piriform opening, and then from that incision, you see, I combine. So here to the bone, I reach the piriform opening. Here, often what you can have is the second surgeon with you, with the section shows you exactly where is the ridge of the piriform opening. Then you follow it inferiorly. You see here, to the cheek, to the nose. To the cheek, to the nose, okay? Then you turn down, level with the floor of the nasal fossa. And then in that inferior meatus, you may see the Hasner valve up there. It's a bit edematous, but it's there. So you are not concerned with it. Huh? You cut inferiorly far from it. So again, to the bone, not too much. Let's say 2 centimeters if it's easy for you to measure in the nose. And then you try to elevate this flap without killing it, because in the end, it will be sutured from here to here, okay? So then I elevate, if I try. Okay, so you may encounter some branches of the fascial arteries through the bone that you may control with patties, obviously, more than coagulation. Bipolar will not be very useful, sometimes a monopolar. So I'm elevating here. You see the branches coming out of the bone, okay? Then here I will be reaching the skeleton of the inferior turbinate just here. So here I'm above the skeleton of the inferior turbinate. Here I will be under the skeleton of the inferior turbinate. So if there is a septal deviation, it might be reasonable to correct it before, because you need some room in that nasal fossa. So again, here I turn and I elevate. Really stay on bone. Don't kill the flap. Okay, so when this is done, sometimes you cut too posteriorly, then you will have a mucosal overhang, which will be really a trouble, okay? So we're done with that. Then I dissect a little bit more to open this approach like a book. I would like this flap to be folded that way. So I detach here from the skeleton of the inferior turbinate. We're going to reach more or less the lacrimal canal when it comes out, the mucosal canal when it comes out of the bony part. So be cautious, delicate. That's why I'm happy to have this attachment here. If the incision goes down, then the flap is falling. So you keep it attached up here, okay? So then we're more or less done with the exposure. And then you need someone skilled like Castelnuovo to demonstrate the removal of bone, a delicate removal of bone with chisel. So if I'm lucky, you can eventually fold it, maybe with some more elevation here, not too much. But you see that the instrument is always far. Eventually, you put a patty to hold it, okay? I don't have patty. Okay, now I want to keep, on the first basis, I keep the piriform opening intact. I want to remove the skeleton here in that area, and then I will go inside that space and I will find the passage to the maxillary sinus here. So first, chips of bone to remove this. C'est vrai qu'il brûle. Thank you. Position of the head is unusual. Okay. So don't do fractures, but you see chips. Okay. So progressively, you see, I change the orientation of the chisel to avoid taking a large piece of bone away, but just chips. Okay. I will have to clean this again. Beware of the noise. If you see that it's a full noise, it means you're breaking a big bone. Up. So again. If you are a bit massive, what happens is that you break the bony lacrimal canal, which is just above. Thank you. Oui, on va nettoyer. Need to clean. So you take all those pieces of bone away. If you have a very nice drill, you may use it, but you have to be concerned not to damage the flap with the burr, obviously. Fais un petit trou. OK. Je veux bien, vas-y. Vas-y, vas-y. Oui. Voilà, là, voilà. And now you heard a noise, and I think the bone cracked here at the level of the lacrimal duct. So maybe I can take a kerrison and open from bottom to top. Usually you need a 2 millimeter kerrison with the foot plate looking forward, not backward like this one, okay? You see the tissue that's appearing here. Gently, okay? You see it's thicker than in the other areas. I will clean, sorry, yeah? A minute. Oui, je vais décoller. Mm-hmm. Okay, that way. Okay, and then you need to, you keep, I told you, you keep the piriform opening, but then you need to find a way to the maxillary sinus. So if I shoot here, I go to the cheek, it is not needed. So I need to be a little bit more posterior. And then if I remove that bone, I should enter the maxillary sinus, okay? And I think that this is the lacrimal duct, and this is the medial wall of lateral wall, sorry, of the lacrimal duct, and then my maxillary sinus is here. You see it. You see? So now, do you agree? No, you don't agree? Okay.
Yes, we do.
Thank you. So piriform opening, I leave it, and then here I go laterally. I think the chisel is a little bit dead. Okay. Okay. Now it's coming. But the problem will be we are to have a nice exposure. We are a little bit too posterior. The difficult thing is to be really as anterior as possible. Okay. See? Voilà. Right. Okay. So for the sake of time, I open here a little bit. So you see that I have plenty of pieces of bone I need to remove. But here you have the bony flap. You have the duct here. You have the lateral wall of the duct, which is still here. I'm going to remove. I can break it down. And then after some cleaning, you will see the opening. So in real life, could be bleeding. So you would stop and put patties with 1 to 10,000 epinephrine. And you would resume the work after 1 or 2 minutes. And it would allow you to have very nice working conditions. Hop. Merci. Some cleaning again. If I have, so look, thank you. If you look anteriorly, it's a bit tricky because you want to be as anterior as possible, but you don't want to go to the cheek, okay? This is the way to the cheek. This is the way of the extended approach of Sturman-Canfield when you elevate till you find V2. While here we just want to go to the maxillary sinus. So here we go to the maxillary sinus, but here it might be, I don't know if it's a maxillary sinus or it's a cheek. We'll see after. Okay, so I open here, and then I can enlarge either with regular forceps. Yeah, I think here, this can be cut. So you see here, I'm starting to transpose the lacrimal canal medially because I'm removing the bone around, taking care, of course, not to injure the canal itself. Oh. Thank you. Okay. Then if I have a backbiter, est-ce qu'on a une pince rétrograde, tu crois? You can use a backbiter. Otherwise, the burr, we don't have. Backbiter? Thank you very much. So, je me brûle les doigts. You enter the sinus, and you see whether you have still overhang. Okay. And if you want to do more, then the burr would be reasonable and not the chisel further on. Non, attends, je finis ça. Okay, so already what we might see, t'as la pince droite? Oui, d'accord, okay. I follow the recommendation of my tutor, Professor Bresson. Okay, here we go. Clean a little bit more. Up anteriorly. So normally you want to reach up the level of the floor of the orbit. So you see I'm too low. So I'm coming up. I try to see it. Don't bite the lacrimal canal, okay? That you see more and more. So actually my transposition is not working that well because here it's a bit narrow and I still have the medial wall of the lacrimal duct. So this is the lacrimal duct, and actually dead bone on that side, you see, prevents me to medialize it. So I break it, eventually I move it out. Yeah. And so now you see I can push it and make my way. And now possibly through the sinus, we'll see where is the flow of the orbit. It's a little bit upper, okay? Thank you. Good, excellent. Thank you. I'm not sure I managed to. Yeah. Then, anteriorly. Ah, mais elle est bien cette Kirison. This is a good Kirison, thank you. Encore un peu. Of course, take care not to injure that flap during the whole procedure. And so either you stay a little bit behind, as I do, or you drill at the entrance. But if you drill at the entrance, you will have some dysesthesia of the second tooth because there is a nerve on the piriform opening side. So if I drill here, probably I would have this transient dysesthesia. Usually it's not really an issue. So again, moving the lacrimal canal. Now it works, okay, you see? Sorry. Keep clean. Okay, now there we are. Now we have the maxillary sinus. And so you can see the posterior wall. You can see the roof. You can see V2 probably just upon my instruments. And inferiorly, you have to take care because, look, if I do that, you say, but why is there this ridge here, you see, coming down? It's very common that the infraorbital nerve, instead of going straight, it goes a little bit down. It can be exposed in that area. So anteriorly, take care not to curate on V2 would be a pity. So the limits are to transpose the lacrimal pathway as I did, to reach up, eventually with some drilling here, the level of the flow. You see, it's still a little bit upper. Yeah, but the position of the head is awful, but well. I move the duct first. Eventually, you can do this. First, put the Kirison in the canal so you are sure you don't kill the canal itself. Then the Professor Bresson is moving, maybe. Yeah, he's moving the canal away. So with the Kirison, I can also take the posterior wall. Some mucosa. Eventually, I would need a burr to remove this. Attends. Yeah, works. Sorry. Okay, so for the sake of time, I won't keep you on that approach all the afternoon. So you have seen the main, and in the end, when you're done, you would just take with the forceps the tip of the flap. You would bring it here and just put one stitch here, and that's all. Okay, so I go back here. And so the good thing to do is to transpose the lacrimal pathway with Hasner valve, etc., so that you have an enlarged view. Imagine I want to remove the medial wall. I can remove bone and mucosa on the medial wall just that way, okay? For the sake of time, I didn't show, but usually we start with an arthrostomy to be able to control the cavity afterward, because if you put the stitch, you may not be able to control anymore the thing. And secondly, in a few situations, you might need to remove really that bone here. So you keep the anterior part of the flap intact, and eventually you can do this extension, which a variation of the Sturman Canfield. You detach the periosteum from the anterior aspect of the maxilla, and normally, if you do it progressively, it will bring you, I think I'm a little bit too attached here. The piriform opening is not exposed enough. Okay. I clean, and normally we should find. But again, normally you would not go in that place. I just do it for the sake of demonstrating the anatomy. Try to open the corridor with a cottle. The first who see V2 gains an espresso. Okay. It's tough to put the scope in the slit, this cleft. Maybe I can detach. Yeah, okay. I enlarge a little bit. Always on bone. Don't pull on the soft tissues. And it should be. Merde. Tu me dis quand tu le vois. You could reach the orbit rim, which is not the target, and possibly is burning. Yeah, you can, exactly, good tip. It arrives down there. So I measure the distance with that. So I should have the same distance here. Voilà. Merde, mais pourquoi j'arrive pas à foutre l'endoscope? Je suis trop bête. I'm just atop the. I have an overhang that makes things a little bit more difficult. Okay. It is there. Okay. Okay. But usually you wouldn't do that. You would just stay on that part, okay? And then if ever you consider that whatever you need to reach is not well explored that way, you may switch your mind and cut at that level, cut the lacrimal duct a little bit upper here at the level of the floor of the orbit, and then remove completely all that part, inferior turbinate and medial wall, and that would be the total medial maxillectomy. So please go work on your side, and I will probably complete the medial maxillectomy so that the place is free to go for a transperiod later on. Thank you.